She's triple negative, has a very, very aggressive tumor. Instead of going on spring break that year, she sat in our chemo room and got chemo. Her friends from college are good to try to, keep her involved and try to surround her and encourage her. But they're right now in very, very different spots in their lives. She's fighting for her life. Her friends are fighting for the grade they get in a class. And that's different.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Kristi Orbaugh, nurse practitioner at Community Hospital North Cancer Center in Indianapolis, Indiana, about considerations for adolescent and young adult patients with metastatic breast cancer. This podcast episode was developed by ONS through a sponsorship from Lilly. ONS is solely responsible for the criteria, objectives, content, quality, and scientific integrity of its programs and publications. Welcome back, and thanks so much for joining us again today, Kristi.
Hey, it's good to be back, Jaime.
And so we've talked earlier this year about difficult conversations about metastatic breast cancer and strategies for discussing disease progression with metastatic breast cancer. Today, we're going to talk about another situation a little bit unique and challenging for nurses, and that is to discuss metastatic breast cancer for patients who are younger in that adolescent and young adult population. So can you tell us a little bit about metastatic breast cancer in the adolescent and young adult population?
Let's just lay some groundwork for this group. So what age groups are we really talking about? Well, when we use adolescent and young adult, we're really talking about age 19 to 35. Some groups will say 15 to 39, but right around that age. When we think about that age, Jaime, think about what all could be going on during those ages. I mean, late teenagers, they may be going off to college, they may be graduating high school, trying to set up their own life, trying to become independent from mom and dad. If you're talking about early to mid 30s, you could be talking about young parents, young career folks. So just setting that into place makes you realize this can be a very tumultuous time for folks. That's when we're trying to understand ourselves, trying to understand our purpose, trying to understand who we are in this big universe. If you're a numbers person, this year alone, we'll diagnose about 300,000 new cases of breast cancer. When we're talking about invasive disease cancer, that age group that we're talking about only makes up about 5.6%. Yet, it's a very, very difficult group to treat. Not difficult as in they are difficult, but just difficult because of where they are in life. Young people aren't supposed to have cancer. Let's face it, Jaime, no one's supposed to have cancer.
Well, right, yes.
We wish we live in a world where you and I didn't have to talk about cancer, but especially young people are not supposed to have cancer. So there's some disbelief in these types of diagnoses. And many times there is a delay in diagnosis because young people aren't supposed to have breast cancer. Young people don't get mammograms on a regular basis. Now, I think we're getting better about that right now that we're understanding more children of folks that have BRCA mutations or significant family history. I think we're starting screening earlier, but still that group in general gets diagnosed later because they're not supposed to have cancer.
And so let's talk a little bit about the actual clinical details of that, the breast cancer diagnosis for this population. Are there more common cancer subtypes for the AYA population? And are there any significant differences in how that is treated versus maybe our more typical aged population?
Unfortunately, this group tends to have more aggressive subtypes. We see more triple negative in this group. We see more hormone negative, HER2 positive in this group. Normal breast cancer cells should be stimulated by hormone. They are stimulated by hormones. So when you have a breast cancer cell that is not driven by hormones, it's much more difficult to treat. We tend to see more aggressiveness in these tumors. We also see a higher incidence in non-Caucasian folks in this age group in compared to the older age groups.
You mentioned the obvious psychosocial issues that surround receiving a cancer diagnosis when you're in this adolescent and young adult population. So, how do you see oncology nurses helping to support these patients in addressing these types of issues?
They do have a lot of issues to address. We need to make sure, number one, we're understanding where they are in their developmental stage. This is an emotional roller coaster. We look at things from the psychosocial. This is disrupting their careers, their life goals, their family planning. I had a patient look at me the other day, and she is not with a significant other, but she wants to consider dating. And she said, when do I tell them that I only have one breast? When do I tell them that I may not be able to have children? She said, is that a conversation you have on your first or second date? So they have a lot to think about. And think about where we are right now, especially in the United States, in terms of social media, how we look, how we act, what we wear, how we fix our hair. There's a lot of pressure on our outward appearance, and especially in younger folks. How do you fix your hair if you don't have any hair? How do you choose what you're going to wear so your port doesn't show or your scars don't show? All of those things are in the forefront sometimes in this age group.
Well, along those lines, in the AYA population, if they are diagnosed with breast cancer, and if it's originally an earlier stage and part of their treatment involves mastectomy or other surgeries that would leave them with scars, that can create body image issues, as you just mentioned. And so, are there certain ways that you think nurses can support these patients who are coping with body image changes that have come from their treatment?
Absolutely. We have to hear them. They're not being vain. This is unexpected. This is not what they imagined. They have scars that may remain forever. What if we gave them chemo and we have a 24-year-old patient that we have now thrown through menopause? So there are those symptoms. Then there's the sexuality piece and how that can be affected. And sometimes that's a difficult discussion to have. I have a patient that I'm thinking about right now, and fortunately, she did have a non-hormone driven breast cancer. It was found relatively early. She underwent a lumpectomy. She did get chemo and she got radiation. Fast forward 6 years down the road, and her oncologist felt like it was safe for her to attempt to get pregnant. Fortunately, she did get pregnant and she wanted to nurse her baby. Because she'd had radiation, she just did not make enough milk. That was very, very, very difficult to her because that was something she'd always wanted to do. We may say, well, formula is great now, just give the baby a bottle, but that's not how she had pictured it. That's one more thing that cancer took from her, which seemed very, very, very unfair. And then, of course, you have the patient that gets diagnosed while they're pregnant. And that can be very, very difficult.
You bring up a great point when we are talking with patients and caring for patients in this younger age group. We have to be able to, in our minds, fast forward. What are the things that they are going to hopefully go through? When we are able to treat this and manage this disease for them, what are things down the road that are possibilities for them that we need to be able to discuss? And now whether that the treatment that we have to recommend might eliminate those possibilities or not, just being aware of what is all possible for these patients as their life continues to move forward. And so being able to talk about all of these things, and they may not have answers for what they want or what they care about at the time, but just being able to kind of speak about them and bring them up is so important because, as you've just mentioned, there are expectations, whether they're known or even set at that point. And so it's important for us to try to think of all of those things that could change because of the diagnosis and the treatment, and giving that patient an opportunity to make choices that might impact those things.
And I think we have gotten much better about understanding the importance of fertility conservation and getting reproductive endocrinologists in sooner rather than later if we have earlier stage cancers and we have patients that want to try to preserve eggs, preserve fertility, sperm banking, all of those things. If you have time, now there are cases where you have something very, very aggressive going on and time is of the essence. But if you have that time to talk to them, maybe a 21-year-old, the primary thing on her mind is not how many children she wants to have one day. Maybe she's not even thought about having kids yet, but still a question you need to have. Do you want to try to preserve fertility? Do you want to try to harvest some eggs? That's a conversation that needs to be had and is very, very important for that age group.
Do you maybe have a case study or an example of a patient in this AYA age group that was diagnosed with metastatic breast cancer? And what were some of the unique aspects of communicating that diagnosis for that young patient?
One patient is standing out in my mind. I have a couple that I have seen fairly recently, but one in particular is a young breast cancer patient. Let's call her Betsy. Betsy is a sophomore in college, so trying very hard to be independent from her parents, active at her college, is in a sorority, is planning where she's going to go on spring break. And lo and behold, notices a very funny lump when she's trying on swimsuits and really had to fight to get someone to listen to her about this lump because she is 22. Well, now she's 23, but she was 22. And unfortunately, she had metastatic disease at the outset. That was a big thing. She's triple negative, has a very, very aggressive tumor. Instead of going on spring break that year, she sat in our chemo room and got chemo. Her friends from college are good to try to, keep her involved and try to surround her and encourage her. But they're right now in very, very different spots in their lives. She's fighting for her life. Her friends are fighting for the grade they get in a class. And that's different. That's very, very different. Recently, we've really come to understand the term cancer ghosting. And that does happen, not just in this age group. It happens in all age groups. Some people just don't know what to say, so they don't say anything at all, which is difficult. They don't know what to do, so they just don't come around. I'm thinking of Betsy. She wants to talk about other things besides how her chemo's going. She wants to talk about the Era tour, Taylor Swift, and, those things that she's supposed to be talking about. It's difficult. That age group is very, very, very difficult. She's got wonderful parents, wonderful, wonderful parents, but she was trying very hard to be independent of them. And now suddenly they have to swoop in and care for her. That's difficult too.
Well, you bring up a good point. I mean, I think we acknowledge the challenge of patients in this AYA age group where maybe they have their own children. So they're a little bit further on in that age group, maybe late 20s or early 30s. And so understanding how to help them talk with their children about it. But I think you bring up a great point of these younger age groups, early mid 20s. They don't have kids yet, but it seems unfair that the burden also falls to them to coach up their friends and their family of how to approach them about that. But it just does, I think, bring to the surface of that's a different, but it's still equally important relationship that we need to consider as nurses. How can we address that if their friends do come to their treatment, or if we do have that opportunity to interact with the friends of a young patient? How can we encourage them to communicate and to help support that patient as a friend and not necessarily as a family member or a caregiver.
Think about how we feel about our peers. I think about some of my best friends of life and how important their presence in my life is. I certainly wouldn't want to be ghosted by them so if we can help guide these young folks along in how to be there for their friend in this particular case, at our clinic, we usually kind of have a little rule that no more than two people as support people in the chemo room. We have individual chemo suites, we're very, very blessed to have that luxury. And we usually say just two guests to a room with each patient. And when she has five or six of her sorority sisters or her college friends there in the room, we just kind of turn the other way. When they DoorDash pizza, you know, it's all good because that's what she needs right then. The other thing is, I think that age group and older as well, young mothers or not even young mothers, 30 somethings that are looking out at the vast future of their career and they have these career goals and they want to accomplish this and they want to accomplish that. And suddenly they're diagnosed with this metastatic disease or at least advanced disease, and that future changes. I think one thing that helps is if you can get them, again, reputable support groups with people their own age that are going through what they're going through. Someone else that doesn't have hair, someone else that isn't going to make it to the big board meeting or isn't going to get the promotion this year because they've had to take a medical leave, someone else that understands it differently. I've been in oncology years and years, my entire career, actually. I've never done anything different, but I've always done it from the position of a healthcare provider. I've never done it in terms of being a patient. And so I can love on those patients. I can encourage them. I can pray for them. I can hug them. I can support them. I can listen to them. But I don't truly, at the heart of it, understand what they're going through because I've never gone through it.
If we think about maybe the same patient or if there's another patient that comes to mind, how was biomarker testing discussed when this diagnosis was first revealed? Was there anything that you feel like you did or said to ensure that they understood the importance of those results?
At our particular clinic, we are I'm going to use the word aggressive in biomarker testing for all disease states. And so that's something that's done up front. Actually, in breast cancer, many of those biomarkers just get reflexed. And what I mean by reflexed is a breast cancer pathology comes through or a breast cancer specimen comes through and it just automatically gets tested for XYZ, HER2, and of course, ERPR. And now we understand that we don't just need to know whether they're HER2 positive or HER2 negative. We need to know what is the IHC score. And even if the IHC score is 0, is there any membrane staining? And then we need to know what's their ESR1, their P10, their AKT, their PIK3CA. Those are so important to know. And so we're going to just start out with that. We're going to tell them we're trying to find out what's driving your tumor. That's what we're trying to do. We're going to be testing for this along the way in case your tumor mutates and develops a new driver or a new mutation that is signaling that nucleus to grow and divide, grow and divide. And that's the last thing we want a cancer cell to do. So we start talking really at the first or second office visit about biomarker testing. And that's just a constant conversation that we have throughout the treatment journey.
And so in this setting, talk a little bit about having that discussion about treatment goals, kind of long-term surveillance. When you have that discussion with a patient who presents with already metastatic disease, that can certainly change not only the therapies that would be recommended, but sort of that long-term conversation as well. So can you talk a little bit more about how not only her immediate treatment options were presented, but how did you discuss what could or would come next?
I think the most important thing when we have this patient that now has stage 4 disease. We need to assure them that stage 4 disease in 2025 looks very, very different. Looks very different. I love to use my patient that has now had stage 4 disease, breast cancer for well over 7 years and is still on first line therapy and looks wonderful, healthy, and carries on a perfectly normal life. That doesn't always happen, but that can happen. And so we need to put that out there. Just because you have stage 4 does not mean that we're at the end of the journey. There are still usually very many treatment options. And I always like to talk about where we are in medicine, in the world of oncology. How we treat patients 2 years ago is not at all how we treat patients now. And 3 years from now, it's not going to be how we treat patients. There's an ever evolving treatment environment that's ever changing, ever evolving, new regimens, new drugs, new procedures, all of which are very, very, very promising for these folks. So I think we have to remain positive in this, not be unrealistic, but positive. I think it's also okay to have the discussion of what toxicities might they incur and what toxicities seem absolutely unreasonable for them. I think that's an important discussion to have.
Well, I think those are all really important points that you bring up in such a challenging situation. The already metastatic at original diagnosis on top of a young patient. I think more than maybe the average patient, there's that a risk for assuming the worst. I think you're very spot on in reminding us that we need to keep all the options open and encourage them to not assume the worst and allow us to kind of take them through their treatment step by step. Because as you said, treatments are changing rapidly every day. It seems as though a new approval comes out. And so young patients may have connections to other family members that have had cancer, the older family members that have had cancer, or what they see in the media or how it's portrayed there. And so especially important for them to be reminded that their circumstances, their cancer itself is unique. And so the treatments that they will be recommended and their response to that can't and shouldn't be compared to anyone's because it is so unique. And so it will be important to get ahead of maybe some of those assumptions and just encourage them to share their concerns, share their fears so that we can provide them with accurate information for what applies to them in their scenario.
A couple of case studies I had in young mothers come to mind that I'd like to share with you. One got diagnosed when she was 5 months pregnant with her first child, which, as you know, isn't that unusual because when do we see hormones? Her tumor was hormone driven, but when do we see hormones more in a disarray, if you will, than when a woman is pregnant? So we held off. Interestingly enough, you can give adriamycin and Cytoxan once the mother hits her 3rd trimester. So we held off treatment until she got to her 3rd trimester, went ahead and gave 2 cycles of adriamycin and Cytoxan. They took the baby early. Then we held off and gave her 2 weeks to nurse the baby because that was really, number one, it was important to the baby. And number 2, it was really important to her. And then we finished up her treatment and moved on to a taxane after that. I'm happy to report I saw her recently. The little guy is now in 2nd grade. And she is fine. She is still alive without disease. And she was 31 when she was diagnosed. So that's one of those really, really happy stories that I don't like to forget. And then I had another patient similar in her pregnancy. And when we found out that she had a malignancy, unfortunately, she had stage 4 at the outset and had presented with a very low back pain. And, she's pregnant. So everyone kind of blamed it on her pregnancy. Unfortunately, that's not what it was. They took the baby early, 6 weeks early, then had to radiate her, then started conventional therapy. Unfortunately, she did pass. but she passed when the little guy was 6. So she still had a lot of really, really good time with him. Now, that's not 6 years is never enough time, but you have to remember those types of stories too. And one thing that was important to her, and, we really haven't covered this, but when she knew the end was coming, she made a lot of tapes, recordings of her voice and recordings of things that she would advise, motherly advice. So they have all that. They can give that to the little guy. Actually had an older sister, so she was her second pregnancy. Those kids have something because the mother was very proactive. And once she knew that she probably wasn't going to beat this nasty disease, she wanted to leave something for them. And she certainly did.
And I think that just emphasizes the importance of having those difficult conversations early and often when they are appropriate, when we feel like the reality, the likelihood of a certain outcome being the patient's future. I think the sooner we have those conversations and reinforce those conversations, such as goals of care and advanced care planning, it gives that patient and their family as much time as we can give them to prepare for that outcome. And as she gave a great example of all the meaningful things that can still happen in the time that they do have, just emphasizes that despite the discomfort of having challenging conversations for patients who are diagnosed with metastatic and potentially progressive disease, we're giving them a gift of time. The sooner we have those conversations and help them to clearly understand kind of what their future may hold. It's just a great story to reinforce that. Kristi, are there any resources that you routinely recommend to support patients, their families, potentially their children, if they are in this AYA population, that can help support them during all of these challenging scenarios that we've talked about today?
I do have some websites that I really like that I think are very appropriate and reputable. Young Survival Coalition is a great one. Life Interrupted is another real good one. It's, if you know Michael Strahan, he is on Good Morning America, as well as used to play professional football, I believe, for the Giants. And his daughter does not have breast cancer, but she has a brain tumor. And typical story, gets diagnosed in the midst of college. And, this is a podcast of her journey, which is really, really powerful. There's another great website called stupidcancer.org for this age group. And then one of my favorites, specific for more sexuality changes and scars and dealing with issues of intimacy. And it's called The Elephant and the Tea. Tea as in, iced tea. It's for the elephant in the room and spilling the tea. And it's delightful. I actually spent a long time yesterday on that website, just reading things and going through it. And this is a website I'm going to recommend a lot. It really answers a lot of questions appropriately, and questions that patients might not feel totally comfortable asking their healthcare team. We always want them to feel comfortable asking us anything, but sometimes I think it's good to have answers reinforced in various ways. And those are just some of my favorites. Of course, Live Strong. I didn't mention Live Strong, ACS, NCI, all of those have great resources.
So, Kristi, how do you think we as healthcare professionals, as oncology nurses, should kind of stop to pause and evaluate any assumptions or implicit biases that we might hold about AYA patients who have metastatic breast cancer?
I think it's important to try to remember what our priorities were when we were in our 20s, what our priorities were when we were starting out as young mothers or starting out our career, because that's where these folks are, or what our priorities were. I have wonderful parents, and I'm blessed to still have my parents alive. But I can't imagine in the midst of college, when I'm trying to be Miss Independent, to suddenly have to be at home and rely on my mom to take me to my chemo appointment and, all of those types of things. So I think one really important bias is to remember where they are in the developmental stages of life. They're not 40 something. They haven't lived X amount of life. And we need to take a step back and try to remember when we were their age, what was important to us? Where were our priorities at that point? And then hear them when they're telling us what's important to them.
What do you think is a common misconception about patients in the AYA age group who have a metastatic breast cancer diagnosis?
Misconception is that it's super rare. We know that that's not necessarily the case. And we know that actually we have seen an increase in diagnosis in that age group by about 0.3% yearly since 2013. So I think we can't assume, oh, that lump is nothing because you're 27 and 27-year-olds don't get breast cancer. That needs to be addressed. And all healthcare providers need to be thinking about those things. The other thing is that they're egocentric. That's part of their developmental stage. That's appropriate at that age. We need to realize that things that are important to them, we may think are ridiculous or petty or inappropriate. They live in a world where it's all out on social media. It's all out there. They see what their friends are doing. They see what's happening at college. They see their colleagues at work being promoted, all of these things. And there they sit in their chemo room. That's not fair, and that's not right, and that's not where they ought to be.
What's something about this topic that's not often discussed, but you wish people knew more about?
From a female standpoint, I think the fact that we frequently throw these patients into menopause or have early menopausal symptoms. And I think we forget how devastating that can be. First of all, young women are addicted to estrogen. That's how our body is made. And to suddenly take a body that's been fueled by estrogen, and frequently these folks go through early menopause, they now are at higher risk for osteopenia or osteoporosis. That in a younger person, knowing that they may have several years ahead of them, needs to be addressed. And then we tell people, be as normal as possible. Get back and do those normal things. Well, they're in a relationship and they want to be intimate. Suddenly, having sexual intercourse is incredibly painful, very, very painful. Or if it's not painful, sometimes they've just lost pure interest in that. They don't feel confident about their body. All of those things that needs to be addressed because patients are trying to live each day as normally as possible. Having a diagnosis of cancer has just ripped the rug of normalcy right out from under them. They don't feel like they used to feel. They don't look like they used to look. And many times they don't even think like they used to think because now they have all of these other concerns that they have to take into account.
What additional training or education do you recommend for oncology nurses so that they can stay current on this topic?
Stay up to date on all of the webcast, podcast, educational offerings that ONS has, that ASCO has regarding these topics. Seek out information on these topics. Seek out information on peri and postmenopausal symptoms, understanding conversations that need to be held around sexual encounters. I think we're much, much better now about talking about those things. But I remember in the past having a patient just devastated by her postmenopausal symptoms. She happened to have a hormone-driven cancer, so there was nothing we could do in terms of adding hormonal replacement therapy. And she said, I went to bed one night at 36 years old and woke up and I feel like I'm 66. And she was mad about it. I don't blame her, Jaime. I don't blame her. That's not fair. And that's not what her late 30s should have looked like. That's the cards that she was dealt. Helping folks feel normal in their new normal and acknowledging that normal now most likely is not what normal used to be.
Well, Kristi, thank you so much for joining us on today's podcast. It's been a difficult conversation and topic to discuss, but important. And I hope that our listeners agree and feel like this has provided them some things to consider if they do help to care for patients that are in an AYA population group with a diagnosis of metastatic breast cancer. So thank you so much again for your time today. Do you have any final comments to share with our listeners?
I think probably the most important piece of wisdom, advice, I don't know that I should use the word wisdom, a piece of encouragement. I just want to remind those oncology nurses that might be listening to this, those patients in that population may need us more than any other population. They may just need us to listen, to be their cheerleaders, to be their sounding block, to be their source of information. And we just need to make sure that we're approaching them with very open hands, open minds, open hearts. We don't have to know all the answers, but we certainly need to be prepared to help the patient find those answers and find resources that might help them. Just because normal doesn't look like what it used to look like doesn't mean that the new normal can't be rewarding. And we need to remember to really encourage patients with that.
So well said. Thank you again, Kristi.
Thank you, Jaime.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.